Welcome to Red, White, and Blue. From the right, I'm Gary Polland.
And tonight, from the left, I'm David Jones.
Always on the left. Tonight we welcome Dr. Andrew von Eschenbach, who currently serves as Senior Advisor at Greenleaf Health and as an Adjunct Professor at the University of Texas MD Anderson Cancer Center. In September of 2005, he was appointed Commissioner of the Food and Drug Administration. Dr. von Eschenbach joined the FDA after serving 4 years as Director of the National Cancer Institute at the National Institute of Health. In 2006, he was named one of Time Magazine's 100 most influential people to shape the world. Our other guest is Dr. Guy Clifton. He is a professor of neurosurgery at the University of Texas Medical School here in Houston, where he was founding chairman of the neurosurgery department. Dr. Clifton was a 2006-2007 Robert Wood Johnson Foundation Health Fellow in Washington, D.C. He has also authored the book Flatline, Resuscitating American Medicine, released in January 2009, and a must-read.
Thank you.
Welcome, gentlemen.
Glad to have you here. So you say in Flatline that we have about a decade to get our hands around this problem of the costs of this healthcare system. How good are we right now, or how, I guess you could say, how much progress do you think we're making with the bills that are being talked about in getting some controls within the 10 years?
I think that people in Washington have identified the problem. People that are making healthcare law understand what we need to do. And basically the issue is there's pretty good evidence about 30% of services delivered in healthcare in the United States are unnecessary, things you don't want and don't need. And it's uncoordinated care, duplication. They don't know what to do about it, I would say. In looking at all the bills and having been in the offices where they were crafting these bills, I think there is no plan on how to get from where we are to where we want to be, which is a problem.
Well, stepping back, Dr. von Eschenbach, how would you describe the healthcare problems we face in America today?
Well, as Guy is pointing out, I think there's a great deal of confusion in this discussion. First of all, with regard to health care, we have the finest health care in the world. It is the healthcare delivery system that's broken. So what we really have to do is to look at that system and look at it, as Guy is talking about, in a comprehensive way and make systematic and systemic changes. The system is inefficient. There's too much waste in it. It's too costly. And it's not delivering the care to patients where and when they need it. So we have to fix that, and fix that in a way that's comprehensive. It's not going to be a simple one-time magic wand, and it can't get done in just a few months. It's going to have to be a commitment on the part of this nation over the next few years to change our healthcare delivery system to match it to the quality of the healthcare that we have available to us today.
And you're both doctors and you're both surgeons, and you probably would concede that your profession has some responsibilities here. I understand that in 2006 there were 60 million surgical procedures, more than any other Western nation, you'd probably combined in that number. 1 out of every 5 Americans had a procedure. So how do we rein in your guys?
Well, it's not a matter of reining in as much as it is a matter of disciplining, from the point of view that we have to make sure that the care that we're delivering is appropriate for the individual patient who needs it. As Guy is pointing out, we don't always give appropriate care. Oftentimes it's inappropriate. It's not an operation that someone needs. But when they need it, regardless of what the numbers are, they should have access to it. Do you agree?
I do. What we have, at least in surgery, is kind of good and bad. If you look at the availability in the United States of kidney transplants, heart transplants, no country in the world has the availability that we do of these procedures. We do far more than other people. That's good. We don't have so many people on kidney dialysis. But the bad part of it is, for instance, back fusion, one of the commonest operations done in the United States. All surgical fusions account for something like 2.4% of hospital spending, surgical fusions of the spine. About half of the back fusions done in the country are of unknown benefit. Nobody knows. Half are pretty well proven. So we've got to tighten up on our indications for surgery and I think measure sort of at the end of the year, give a surgeon report card on what you did and how you did it.
How do you do that? How do you determine the 50% or 40% of the back fusions that were appropriate and actually helped cure issues in the 50 or 60% that were just a waste of time and money?
Well, you ask the question, and in a sense, what you do, a couple of ways of doing it. One is to follow people over a 6-month to 1 year period, large groups, thousands of patients who've had surgeries, and see how they did. In many cases, what you do is actually randomize. That is, you tell the patient, we really don't know what the best thing to do here is. Surgery's an option. There's a lot of confusion about it, and you can either, we're going to, if you want to do it, we can put you in a study where we can't tell you whether you're going to have surgery or not have surgery. We're going to compare two groups at the end of the year. That's how we've proven most of the surgeries we've done, I think, or many.
And there's another dimension to that. In addition to doing a study beforehand, we can do a much better job using modern information technologies, which we don't currently have but need. We can do a much better job of tracking what happens to patients after we do a treatment. What we'd call, in terms of, with regard to the FDA's initiative with drugs, post-market surveillance. What happens when a drug goes out into the market and is used by a large population of patients? That knowledge, that data from a post-market surveillance can be used to inform decisions about under what circumstances should you give that drug and under what circumstances should you not give that drug. That would bring a discipline and an appropriateness to care that would improve quality and lower cost.
So right now we're not getting that feedback like we need of how successful these items are.
We're not. We don't have the systems in place. We don't have the information management systems in place to be able to capture that data. We're not doing it in a systematic and systemic way, and it could be a major step in transforming the healthcare delivery system.
Well, when you talked about costs of the system, one of the concerns that I've had, it seems like we reward failure. That is, if you go to the hospital and the hospital treatment isn't very good, you get a staph infection or other kind of complications, you end up spending a whole lot more money in terms of hospital costs, medical bills that cost the system, whoever pays it, the insurance companies, the taxpayers, government, more money. So how do we change the system from rewarding failure to rewarding success?
Well, Guy will have some important things to say about this because this is an area of study. And I'm going to let him speak to reimbursing, not reimbursing for services, but paying for quality. But let me take it from another perspective. One of the things that advances in science and technology are making available to us are opportunities for us to know what the right treatment for the right patient is to get the right outcome. Our most common prescription as physicians growing up was take 2 aspirin and call me in the morning. The reason it's 2 aspirin is because we don't have any idea exactly how much aspirin you should take or exactly how much you should take. Today we're developing tools that are going to enable us to do that, to be much more precise about getting that right treatment and that right dose to that patient. What that does, and at FDA we did a study using the blood thinner Coumadin and looking at if we could use genetic testing to decide what the right dose for Coumadin was for a patient. What it does is eliminates the likelihood of underdosing and patients still having clots, or overdosing and having them come to the emergency room with bleeding as a complication. Just a reduction in those underdosing and overdosing complications results in not only increased quality for every patient, but hundreds of millions of dollars of savings in emergency room visits for complications of one single drug, the blood thinner Coumadin.
So Dr. Clifton, you're
what I
hammered
on in the book was that you get what you pay for in healthcare. And my basic thesis is, and I think a lot of people have come around to this conclusion, that if we have to change the way we pay providers, hospitals, and doctors to get the results we want. And so you asked the question about hospitals, and so let me answer that. First, I have to tell you how hospitals are paid. Private insurance pays either by the day or by the procedure. It's a cost-plus business. That however many things you do plus profit is what you get paid. What that means is, with private insurance, the sicker you get during hospitalization, the more the hospital gets paid. There's a profit margin either way.
So they want you to get staph infections.
No, nobody wants you to get staph infections, but what happens, it sounds like that, but nobody wants that. But what happens is all the financial incentives are against efforts to improve quality because it's essentially not financed. There's a famous story in Intermountain Healthcare, Salt Lake City, one of the better hospitals, probably 2 best hospital systems in the country, where the doctors got together and said, look, we're going to cut our rate of hospital-acquired pneumonia a lot. and they started at about a 12% rate. And they put immense amounts of effort, information systems, doubled the nursing staff, education, plowed a lot of work into getting it down. Within 2 years, they had dropped their hospital-acquired pneumonia rate fourfold to 3%. Great for the patients. Cut their cost $5,000 a patient, and because of the payment system, their patients were healthier. They got paid less. And so all the money they put into doing this was sunken cost. And that's
so
the
there's no financial benefit.
No, well, and actually, on a hospital that's on a tight margin, you don't have the finances to do it. So we have to completely change the incentives.
How do we do that?
Well, I think the way to do it is well, let me tell you another fact you're not going to like. I'll tell you how to do it.
I'm looking for a simple solution here.
You pay up front. Basically, the short answer to it is if you risk adjust surgical patients, that is, you can compare an 85-year-old with colon cancer with a 25-year-old coming in for an appendectomy. If you do these risk adjustments, which the American College of Surgeons has done, you find that the variation in complication rates in among hospitals is 300%. I was astonished by this. So what you do is you basically set a payment rate. That's the rate that a hospital that's doing a good job would make a good profit margin at. You risk adjust the patient up front and say, we're going to pay you and the hospital and the doctors a lump sum.
The concept that we hear coming out of Washington is comparative effectiveness research. Can you give us a little background about that principle that they're trying to work into this new overhaul? It seems like that's what Washington wants, is a complete overhaul. I mean, it's like throw it all out and start all over again, and yet phase it in over a number of years is what I'm hearing.
It's a great question for which we need an entire show to really deal with the detail and the depth of understanding of comparative effectiveness research. There are really two concepts. One is, does something work? How effective is it? Then how well does it work compared to something else? And therefore, can we make a value judgment as to should we purchase this particular service or product or drug because it works better than this one? There is a lot of detail in that discussion that needs to be worked out. One of the concerns that we have is these decisions are made on populations of patients. So you can test one drug against another drug and say this one seems superior in this population. But for you as an individual, you may actually benefit from the drug that didn't fare so well because it was one that was best for you. So comparative effectiveness really needs to take in the concept of personalized medicine and personalized decision.
And it would apply to procedures, not just to drugs, though, right?
It could cry across the board.
There was a Dr. Ho at Baylor who wrote an article in the Chronicle who said that Medicare guidelines for people with heart ailments, blockages, and the like is for first to have is for a stress test before you go to the angioplasty. And yet 50% of them get the angioplasty and never had the test. So it's completely disregarded, and it's $10,000 a pop. So wouldn't comparative effectiveness address that?
Well, that's appropriateness in the sense of is it appropriate to do something as opposed to is something effective. And I draw these distinctions because we can't wind up getting immersed in an adventure that's going to lead us down a road in which we're going to do more harm than good by depriving people of interventions and therapies because they appear to be, in this comparative effectiveness context, not as good as something else.
Well, when I read about comparative effectiveness, my fear is if you're 82 years old and you want hip replacement, we're going to say, well, your life expectancy is too short, so under comparative effectiveness, the answer is no. You don't get it. Take your heavy Tylenol or whatever and deal with the pain.
Well, actually,
isn't that really what we're talking about with the plans being kicked around in Washington?
I think we are so far from the discussion of withholding something that is of, let's say, marginal benefit. I mean, maybe you want a hip replacement so you can play tennis.
But he has a good point.
He has a good point.
Because it can lead to that, and it has led to that.
Yeah.
In England, with NICE, which is their Institute for Comparative Effectiveness, there was such a decision until the Queen had a problem with her hip. And
she came to America and got treatment? Is that what happened?
Well, but my point is, when we're looking at a healthcare system that's got 30-40% documented excess, And this is just stuff you wouldn't want. Hospitalization when you don't need it, excess consultations. If we can wring that out, you're talking about decreasing the overall cost of health care 30%. You don't ever have to get into the discussion as the $48,000 drug that increased your life expectancy 6 months.
Right. So you think we need to do something also in eliminating those costs so that we can get to the 47 million who have no care.
I think it's the way you pay for it.
Exactly.
We
agree.
over.
We are agreeing on the fact that there is much about what's occurring with the delivery of care in which care is being delivered that's inappropriate, excessive, wasteful, and that needs to change. And the question then is, how do you do that?
So we go fee for service, we go single payer, Medicare for all, we go employer mandate or individual mandate. Those are the 4 things I'm hearing. So what gets us there?
I would suggest none of them get us there, David, because if you listen to what the doctors are telling us, they're telling us you've got to wring out. The way we pay doctors and hospitals is wrong. You've got to pay for procedures, for process and not for procedures. Because otherwise,
maybe they should just say whether the House bill, which we all know something about, whether it gets there.
No.
Okay, in fact, while we talk, I got to mention this. I got the diagram from the House bill, and you've seen this. This looks like a very complicated decision-making process to get your things done. I'm a simple guy. I figure you want to get a procedure, you deal with an insurance company and your doctor and you. So it'd be 3 people. This thing, it looks like a Ruby Goldberg contraption. Am I right?
You're asking two very important questions. And as surgeons, we both learned early on in our training that when confronted with a patient who's got a critical problem, our responsibility is to do 2 things. Decide what the right thing to do is, and then do it in the right way. There are certain things that we have to do to correct the problems in healthcare delivery, but we also have to be sure we're doing them in the right way, we're carrying them out in the right way. So some of the ideas of reducing excess are exactly the right thing to do. Now the question is, how do you do that? How do we carry that out? And there are some of the things that are being proposed are really not driving down cost of health care. They're really going to wind up trying to change price, how much you pay for health care. But they're not really truly impacting on the root causes of what is driving the actual cost. They're not getting to the waste that we were just talking about. Whether you use any one of those systems that you described, it will not address the question of waste.
The way I think about this is, there's a hot debate. The biggest debate in Washington right now is whether expansion of coverage to the 47 million uninsured is regulation of the insurance industry and a public program, or just regulation of the insurance industry. I don't support an additional public program because Medicare is going to bankrupt us. But the point is, Medicare could pay, or Blue Cross could pay, any insurer could pay in the same way. It doesn't really matter who pays so much as what they pay for. Is the way I think of this.
That's right.
When I say 30%, if you got a minute, let me tell you where this came from. If you take a patient with heart failure and examine the care of that patient in Miami and in Minneapolis, what we know is the patient in Miami, or Houston actually, gets about 2.5 times more hospitalizations for that condition, sees about 2.5 times more doctors, 2.5 times more consultations, minor procedures, and the mortality rate than in Minnesota. And the mortality rate in Miami is higher. So if you take different regions of the country and look at patterns of practice, you conclude that if people in low-spending areas that have high quality of care, if that were the norm in the country, we would reduce Medicare costs by about 30%. And a lot of it is primary care, which is family physicians, internal medicine, general internists, and pediatricians. What they find in low-cost, high-quality areas is there are a lot of primary care doctors managing the patients comprehensively. And what you find in high-spending areas is a lot of what we both talked about, a lot of technology, a lot of hospital beds that gets really over-deployed. So the job is to even this out. To do it, we've got to massively expand our primary care workforce. I mean,
doctors have to be encouraged to go into primary care as opposed to being surgeons like you two.
Exactly.
And get greater dissemination of the care that we have.
So, but you're not saying that the voter out there, whoever's watching this debate, should be afraid of a public option, are you? I mean, we've got the Veterans Administration that's delivering good care to veterans. We've got
that's debatable.
We've got the soldiers get free medical care. We've got Medicare, and the people who are in Medicare seem to enjoy it. I seem to like the program. I mean, why should we tell people that the public option is a bad idea?
Talk to your mother.
I think we should be afraid of radical and precipitous changes that we don't fully understand the consequences of, because we're dealing with a system. The system needs to be fixed, but it is a system. And if we are changing one part of the system, we could inadvertently be seriously injuring or creating problems with another part of the system. What the American people want is, in my opinion, having taken care of patients, is not cheap health care. They want access to quality health care. They want it available, they want it to be affordable, and they want it to be appropriate, what's right for them. We have things with regard to availability where we know, as Guy was just pointing out, there are people who don't have health care available to them. And we have to change the manpower requirements. We have to get...
Because they can't afford it, right?
Available for them for lots of reasons. One, they may not be able to afford it. It may not even be in their community because they are living in a rural area that doesn't have health care. Or they may be in an urban area where they can't get to the health care. Health care has to actually go to them. Those are barriers. But there's also the issue of the care doesn't even exist at this point. There are patients with cancer and Alzheimer's for which we do not have available treatments, and we have to continue to make sure we're driving that engine of discovery and development that's going to continue to bring those new interventions, those new technologies, which appear to be costly at first glance, but actually in terms of life-saving, really become very cost-effective. We don't want to change a system here that then disrupts our ability to continue to drive that discovery and development and have those treatments available. And that's why we have to be thoughtful about this.
You know, I'm going to answer your question in a little different way. I heard one congressman say, you know, if you're uninsured, you really don't care whether it's a public program or a private program. This is a debate that wealthy people that have insurance have. Poor people don't care.
Call them socialists if you want, right?
They just want insurance. Thank you very much. We have a public program, and I'd like you to find me a patient who had their care rationed by Medicare. Medicare is a public program. My concern about this all is that right now 12% of our income tax pays for Medicare. In 2020, it's 20%. In 2030, it's 34%. So the reason I say, and others do, that we've got about a decade is we've got a Medicare problem. And if a new public program is managed like Medicare, we're going to have a Medicare Plus problem.
A lot quicker.
Quicker.
But the President of the United States is making the same argument you're making.
He is, but he doesn't have a solution for it. That's the problem. If you look at these bills, I can't find a provision that's going to fix any of the things that Andrew and I have been talking about.
Was anyone in Washington listening to informed people involved in the medical profession like y'all?
AMA's endorsed the program.
Having just got back from Washington yesterday, I can tell you that there's a lot of talking and very little listening.
Well, that's unfortunate because it looks like y'all are onto some ideas of how to deal with the over expenses we have in the system now, which can then be used to take care of the truly uninsured, because David wants to talk about the poor not having medical care, but that's not true because they have Medicaid and they've got CHIPs. So the poor do have coverage. You have some group, I've looked at statistics say the true uninsured in America is about 8 million. When you talk about people in between jobs, you talk about people that decide they don't want coverage, they're young, they're healthy, they don't care.
Your expert is shaking his head.
Well, I understand. I threw out my ideas.
There's a group in Washington, and these people live or die by the accuracy of their numbers, and I think they've got the best numbers around. It's Urban Institute, John Holohan. Mm-hmm. And the picture of the uninsured is about 50% of them, of the 47 million, are too poor to buy insurance, and that's up to about almost 50,000.
Insurance has gotten very expensive.
It's gotten
expensive. No
expensive.
question about it.
Their employers don't offer it. They can't afford it. About 25% are eligible for public programs but don't sign up for a variety of reasons. And then about 20% anybody would look at and say they can afford it and just don't buy it. So
we've only got 15 seconds. I want somebody to say, answer the question, are we going to have a change this year in healthcare?
We're going to have a change. And I hope that it will be a change that will be incremental and one that will be sustained over a longer period of time, because this is a process, and we have to fix this as a process.
That gentleman knows how to go within 15 seconds. Thanks very much to both of you for being here. You can view a follow-up discussion of tonight's program and find out more about Red, White, and Blue there. Just visit us at HoustonPBS.org, so check that out. And until next time, get informed and get active.